Hello, everybody. This is Jeanne E, the editor-in-chief of Heart Rhythm O2 Journal, and this is the July podcast. We do have a lot of papers, and I will be reading the title, the name of the first author, and the key points or conclusions. The title of the first paper is Characteristics, Pathophysiologic Mechanisms, and Ablation Outcomes of Patients with De Novo Left Atrial Flutter compared with patients with Post-Ablation Left Atrial Flutter by Dr. Valance-Slahiou and colleagues. The first key point is De Novo patients were older, had a lower body mass index, and were more often women. In nearly 1/3 of the patients, no atrial fibrillation had been documented before presentation. Second, differences in arrhythmia mechanisms were observed between the groups. Anteroseptal localized reentry was the most common arrhythmia mechanism in the De Novo group. And third, ablation procedures were generally safe, with no significant difference in complication rates between the two groups. Fourth, catheter ablation demonstrated comparable effectiveness in both cohorts, with no significant difference in arrhythmia-free survival. This paper is followed by an editorial, the title of which is Observations about Left Atrial Tachycardias, Broadening Our Understanding. The author is Stephen Markowitz. The title of the next paper is Impact of Radiofrequency Power Settings on Acute Mitral Isthmus Ablation Success with Concomitant Vein and Marshall Ethanol Infusion by Dr. Antoine DaCosta and colleagues. The first key finding is that this study evaluated the impact of radiofrequency power settings during mitral isthmus ablation performed within a workflow incorporating systematic vein of Marshall ethanol infusion. Second, both 35-watt and 50-watt strategies achieved high rates of acute bidirectional and mitral isthmus block. Third, the use of 50-watt high-power short-duration approach was feasible and improved procedural efficiency with higher first-pass block rates and fewer additional applications without increasing complications. And finally, these findings are limited to acute procedural outcomes and should be considered hypothesis-generating. The title of the next paper is Impaired Left Atrial Strain is Associated with New-Onset Atrial Fibrillation and Adverse Clinical Outcomes in Primary Care Patients by Dr. Jeanne E. and colleagues. The first key finding is that impaired left atrial strain, particularly reduced peak atrial longitudinal strain and left atrial conduit strain, is independently associated with the development of new-onset atrial fibrillation in a primary care population. Second, LA strain provides incremental predictive value beyond left atrial volume index, improving discrimination and risk reclassification for incident AF. Next, lower baseline PALS before AF onset is independently associated with increased risk of all-cause mortality and major cardiovascular events after AF diagnosis. Finally, left atrial strain may serve as a non-invasive marker of atrial myopathy, supporting its potential role in early risk stratification for AF development and long-term complications. The title of the next paper is Amplified P-wave Duration Predicts Incident Atrial Fibrillation in the General Population, Results from the Hamburg City Health Study. The first key finding is that amplified P-wave duration as novel electrocardiogram-based biomarkers predicts incident atrial fibrillation in the general population. Second, prolonged amplified P-wave duration is significantly associated with new-onset atrial fibrillation during a 5-year follow-up period. And third, incorporating amplified P-wave duration improves risk stratification by the CHA2DS2-VASc score for incident atrial fibrillation. The title of the next paper is Intravenous Vernaculant for Acute Termination of Recent Onset Atrial Fibrillation in the Emergency Department by Dr. Karen Heller and colleagues. First key finding is that the authors report a large cohort of consecutive patients receiving vernaculant for the conversion of recent onset atrial fibrillation. 328 patients received intravenous vernaculant and 368 patients, or 82%, converted to sinus rhythm within minutes of drug infusion. Second, the efficacy of vernaculant in the placebo-controlled studies of vernaculant, the conversion rate of recent onset AF has been only 1.5%, 14% after the intravenous infusion of placebo, contrasting with the 37 to 71% conversion rate with intravenous vernaculant in the same studies, clearly demonstrating the high efficacy of this drug for rapid termination of atrial fibrillation. And finally, the safety of Vernaculant. A total of 4,008 patients have received Vernaculant in published randomized controlled and non-randomized clinical trials. 4 of these patients, 0.099%, died after receiving the medication, yet not necessarily considered due to the medication. There's a nice editorial following this paper. The title of the editorial is Vernaculant, Wish You Were Here, by Drs. Judith Mackel and Ohad Z. The title of the next paper is Real-World Data of Sex Differences in Atrial Fibrillation Catheter Ablation, Insights from a Prospective Multi-Center Registry by Dr. Jeanne and colleagues. The first key finding is that in a real-world cohort of 4,202 patients undergoing atrial fibrillation ablation, women were older, had higher chance BAF score, and were more frequently diagnosed as having paroxysmal AFib than men. Second, women underwent more complex ablation procedures, including higher rates of additional substrate modification, particularly posterior wall isolation across both paroxysmal and persistent AF. Third, despite similar acute procedural success, women experienced a higher risk of long-term atrial arrhythmia recurrence and were more likely to undergo repeat ablation after the blanket period. And finally, female sex was an independent predictor of recurrence in ablation strategies, incorporating substrate modification, whereas outcomes were comparable between sexes with pulmonary vein isolation-based approaches alone. Up next is a paper titled Evaluation of Transvenous Lead Extraction in Young Adults, Insights from the University of California San Diego Lead Extraction Registry by Dr. Andrew Jeanne and Annie-Sophia Machargé-Weberge and colleagues. The first key finding is that young adults are referred for lead extraction that devices implanted at a younger age. The most common indications for extraction include lead malfunction, infection, and system upgrade. Lead extraction is safe in young adults. There was no difference in procedural complication and mortality rates between the younger and older cohorts stratified by age for less than 50 and greater than 50 years. However, young adults had increased procedural complexity with findings of longer fluoroscopic time, higher likelihood of needing to upsize the leading sheet or switch to a mechanical rotating sheet, and lower rates of complete procedural success. This paper is followed by an editorial, Time to Rethink Transvenous Systems in Younger Patients, by Dr. Nayani Markar and Youngmei Cha. Up next is a paper that is titled Indications and Electrical Performance of Conventional Resynchronization and Conduction System Pacing in Transthyretin Amyloid, by Dr. Stephen Dubner and colleagues. The first key finding is that the current study is the first to compare conventional cardiac resynchronization therapy and conduction system pacing in transthyretin amyloid cardiomyopathy. The second key finding is that after ATTR-CM diagnosis, indications for cardiac pacing change, and with it the choice of pacemaker system favoring CRT and CSP implantation to minimize the risk of heart failure progression previously described with high-rate ventricular pacing burden. Third, among all pacing modes, CSP resulted in improved electrical resynchronization with shorter paced QRS duration in patients with conduction disease, irrespective of intrinsic QRS morphology. Finally, after a median follow-up of almost 2 years, electrical lead performance after CSP implantation remained stable, without significant differences in sensing or pacing thresholds compared with conventional or CRT pacemakers. This paper is followed by an editorial. The title of the editorial is Marching to a New Beat, Choosing the Right Pacing Strategy in Transthyretin Cardiac Amyloidosis by Drs. Nicholas Wetterston, Marcus Ure, and Gordon Ho. The title of the next paper is Ablation Lesion Patterns in Atrial Fibrillation, a Cardiac MRI Comparison of Different Ablation Strategies by Dr. Niki van Poondergen, Marisa van der Graaf, and colleagues. The first key finding is that late gadolinium enhancement cardiac magnetic resonance, or LGE-CMR, demonstrated ablation modality-specific lesion characteristics with point-by-point radiofrequency, showing the most continuous and homogeneous pulmonary vein encirclement, whereas cryoballoon and single-shot RF produced broader but less uniform lesions. The second key finding is that PFA produced the widest yet most heterogeneous lesion patterns on LGE-CMR, although reported findings varied across studies, likely reflecting fundamental differences in non-thermal ablation lesion formation and limitations of current imaging and post-processing methodologies. Finally, the relationship between CMR-defined lesions and clinical outcomes remains unclear, highlighting that standardization of imaging techniques, thresholds, and methodologies, especially with the rise of non-thermal ablation techniques, is crucial to ensure accurate and consistent assessment of lesion durability across modalities. Next up is a paper titled Training in a Novel Advanced Augmented Reality-Based Ablation Simulator Using Three-Dimensional Magnetic Resonance Heart Models of Individual Patients Improves Performance of Future Electrophysiologists by Dr. Nora Bacha and colleagues. First key finding is that arrhythmias are rising worldwide and efficient training of next-generation electrophysiologists to perform successful catheter ablation is crucial. To allow for training on individual heart anatomies, a novel advanced augmented reality-based simulator was developed and tested. Cardiologists without electrophysiologic formation, non-EPs, and experienced EPs were trained for right atrial flutter ablations using a real ablation catheter and 20 different AAR scenarios displayed on different heart anatomies. Catheter handling skills were trained, but not electrogram interpretation. Non-EPs significantly improved handling skills and improved efficacy and safety of coronary sinus intubation and cable tricuspid line ablation. After training, non-EPs obtained a comparable efficacy and safety profile as experienced EPs. Experienced EPs improved slightly in terms of efficacy. The AAR simulator has the potential to accelerate trainee proficiency and enhance patient safety by enabling the acquisition of essential skills in a controlled, risk-free environment. The simulator also allows practicing rare scenarios, preparing complex individual cases, and managing potential complications without any risk to patients. The title of the next paper is Machine Learning to Classify Left Ventricular Hypertrophy Using Electrocardiographic Feature Extraction by Variational Autoencoder by Dr. Amulya Gupta and colleagues. The first key finding is that vector cardiographic ECG metrics and conventional voltage-based criteria demonstrated moderate discrimination for the diagnosis of left ventricular hypertrophy. In contrast, machine learning models trained on ECG signals achieved superior diagnostic performance. Second, latent representations derived from a pre-trained variational autoencoder enabled the use of computationally efficient tree-based models such as light gradient boosted machine, or LGBM, as an alternative to convolutional neural networks, while achieving comparable or improved classification performance. Finally, the predicted probabilities generated by the fully trained LGBM classifier exhibited a strong linear association with left ventricular mass index, the structural substrate underlying LVH. Further, individuals classified as false positives had a threefold higher risk of subsequent LVH development, suggesting that apparent misclassifications may reflect subclinical or evolving myocardial substrate. Next up is a paper titled Contact Force Sensing-Based Radiofrequency Catheter Ablation and Paroxysmal Supraventricular Tachycardia as a Randomized Controlled Trial. The first key finding is that the use of contact force data during supraventricular tachycardia ablation did not result in a significant reduction in the number of radiofrequency applications, regardless of the arrhythmic substrate. Second, procedural efficacy and safety outcomes were similar between contact force-guided and conventional ablation strategies. Third, the high success rates in both arms suggest a procedural performance ceiling that may not be improved by contact force data alone. The title of the next paper is Impact of Atrial Ventricular Node Ablation and Permanent Pacing on Clinical Outcomes, Quality of Life, and Healthcare Utilization in Patients with Atrial Fibrillation by Dr. Miriam Scheuer, Water, and colleagues. First key finding is that AV node ablation was associated with a substantial reduction in healthcare utilization of patients with refractory atrial fibrillation, including fewer outpatient clinic visits, emergency department visits, Holter analyses, electrocardiograms, electrical cardioversions, and additional AF ablations, and pacemaker implantable cardioverter defibrillator upgrades. Second, quality of life improved in approximately 2/3 of patients 1 year after AV node ablation in both physical and mental health domains. Third, AV node ablation demonstrated favorable safety profile with very low procedural complication rates and no mortality directly related to the procedure. Next, left bundle branch pacing provided similar benefits in healthcare utilization and quality of life as conventional pacing strategies, despite its greater technical complexity. And finally, favorable outcomes were also observed in younger patients, younger than 65 years, suggesting that AV node ablation may be considered in carefully selected younger individuals with therapy-refractory atrial fibrillation. The title of the next paper is Management Algorithm for Pulmonary Vein Stenosis and Evaluation of Available Surgical Data by Dr. Johanna Bauer and colleagues. The first key finding is that if adequate stent implantation fails or restenosis occurs and the patient experiences severe symptoms, pulmonary vein stenosis surgery should be considered. Second, setting the indication for surgery on a case-by-case basis requires interdisciplinary assessment with expertise from cardiology, radiology, and cardiothoracic surgery. Third, surgery such as pulmonary vein patch angioplasty should be reserved for centers with experience in major thoracic surgery under cardiopulmonary bypass. Finally, the author's proposed treatment algorithm may assist in individual treatment decisions and serve as a foundation for future treatment discussions. Next up is a paper titled Predicting Ventricular Arrhythmia in Myocardial Ischemia Using Deep Learning by Dr. Anna Bussato and colleagues. I'm going to read the author's conclusion for this paper. It goes as follows. This study shows that deep learning, specifically LSTM models, can forecast the timing of PVCs during myocardial ischemia from short sequences of epicardial electrograms. The model's accuracy increased as the input sequence length grew from 3 to 7 beats, while its calibration remained highly accurate, suggesting that the remaining prediction errors are primarily due to natural variations, physiologic responses, rather than flaws in the model that could be corrected. We further demonstrated that a pre-trained model can be efficiently adapted to a new subject with a small amount of subject-specific data, yielding substantial statistically reliable error reductions, especially with 5 to 7 beats, and increasing the fraction of predictions within clinically meaningful 30 to 60-second windows. These findings establish the feasibility of predictive modeling from high-resolution electrophysiologic signals, paving the way for real-time personalized tools that shift arrhythmia management towards proactive prevention and improve patient outcomes in ischemic heart disease. The title of the next paper is Ultrasound-Guided Axillary Access Performs Subclavian Puncture for Cardiac Implantable Electronic Device Implantation, a network meta-analysis of 130,831 patients by Dr. Maria Eduarda Marquez Almeida and colleagues. The first key finding is that this network meta-analysis is the first to compare 4 venous access approaches: subclavian, cephalic, fluoroscopy-guided axillary, and ultrasound-guided axillary for cardiac implantable electronic device implantation. Second, ultrasound-guided axillary access demonstrated the best overall safety and radiation profile, while subclavian access achieved higher procedural success but carried an increased risk of complications. Third, findings support an ultrasound-first strategy for venous access during CIED implantation, the subclavian puncture reserved for rescue situations. Finally, standardized operator training in vascular ultrasonography, micropuncture techniques, and procedural checklists is crucial to improve safety, efficiency, and reproducibility across centers. The next paper is titled Peak Frequency Analysis to Identify Critical Isthmus Distribution for Adenosine Triphosphate-Sensitive Atrial Tachycardia by Dr. Satoshi Oka and colleagues. The first key finding is that among 6 typical adenosine triphosphate-sensitive atrial tachycardias, a high-frequency cluster adjacent to the earliest atrial activation site, or EAAS, was identified in 5 cases. Second, orthodromic capture of the EAAS potential was confirmed by pacing from the direction of a high-frequency cluster where AT was successfully ablated. Third, the absence of a high-frequency cluster or a relatively low peak frequency at the EAAS in the right atrium may warrant additional mapping of the left atrium or the non-coronary cusp. The next paper is one of our Fellows Corner cases, and the title is A Unique Case of Left Atrium Posterior Wall Micro-Reentrant Atrial Tachycardia During Sinus Rhythm After Pulsed Field Ablation in a Patient with Mechanical Mitral Valve Replacement, a Novel Case Report. The first author is Dr. Kunaraj Perumalu. The key findings are that first, high-density mapping systems play a critical role in the identification and ablation of micro-reentrant atrial tachycardia. Second, micro-reentrant atrial tachycardia along the left atrial posterior wall is fundamentally linked connective tissue and isotropic effects, particularly in the context of advanced atrial disease or post-ablation scarring. Third, microreactant circuits are often small, less than 1 centimeter squared, and easily misdiagnosed as focal tachycardias or areas of simple scarring when using conventional low-resolution mapping. Emphasis mapping is a critical tool in identifying and treating microreactant atrial tachycardias. The next paper is also a Fellows Corner paper. The title is Extravascular Implantable Cardioverter Defibrillator Implantation in a Pacing-Dependent Patient with a Cardiac Resynchronization Therapy System, a Structured Intraoperative Protocol to Validate Device-Device Interaction by Dr. Jeanne E. and colleagues. The first key finding is that contralateral extravascular implantable cardioverter defibrillator is a viable alternative in pacing-dependent patients with CRT systems when a CRT with defibrillator upgrade carries high procedural risk, avoiding lead extraction and additional transvenous placement. 2. Structured intraoperative electrical validation is essential to identify reliable sensing vectors and prevent oversensing of double counting in complex paced QRS morphologies. Third, postoperative programming optimizes device interaction by maintaining bipolar pacing and adjusting sensing vectors, thereby minimizing interference and ensuring effective therapy delivery. Next up is a research letter. The title is Three-Dimensional Analysis of the Triangle of Cook in Typical Atrial Ventricular Nodal Reentry Tachycardia, Insights Using Peak Frequency Activation Vector and Wave Speed by Dr. Yasuki Sakamoto and colleagues. First key finding is that high peak frequency regions were consistently located in the posterior septum and corresponded to successful slow pathway ablation sites. Second, activation vector analysis demonstrated vector convergence at the high peak frequency region, indicating the electrophysiologic entrance of the right inferior extension. Third, pivot points and vector patterns reflected the anatomical course and depth of the slow pathway within the triangle of Cook. Next, relative wave speed was highest at the high peak frequency region corresponding to the slow pathway entrance. Finally, integrated analysis of peak frequency activation vectors and wave speed provides a novel three-dimensional functional framework for slow pathway localization. The next paper is also a research letter. The title is In-Hospital Outcomes of Elective Atrial Fibrillation Ablation in Patients with COVID-19, a nationwide analysis from the HRO2 DPC database by Dr. Akinori Sairoku and colleagues. The first key finding is that confirmed coronavirus disease during hospitalization was uncommon amongst patients undergoing elective atrial fibrillation ablation, 190 of 1,075, 215 people, or 0.11%. Second, COVID-19 infection was associated with higher in-hospital complication rates, longer hospital stay, and higher hospitalization costs. And third, in multivariate analysis, COVID-19 infection remained independently associated with adverse in-hospital clinical outcomes after adjustment for patient and institutional characteristics. Next up is another research letter. The title is Real-World Comparison of Conduction System Pacing and Helix-Based Leadless Pacemakers and Single-Chamber Pacing Procedural Outcomes from the PaceMan Study by Dr. Benem Subin and colleagues. First key finding. In this multi-center real-world cohort of 103 patients with preserved left ventricular ejection fraction undergoing single-chamber ventricular pacing, leadless pacemaker implantation was associated with shorter total procedural time duration than conduction system pacing, but longer fluoroscopic time. Second, acute procedural success was 100% for LPM implantation, whereas confirmed conduction system capture was achieved in 71% of CSP cases, with failures mainly related to the inability to obtain stable capture with acceptable thresholds. And finally, acute complication rates were low and comparable between strategies, with one LPM dislodgement requiring retrieval and reimplantation, and in the CSP group, one pocket hematoma and one lead dislodgement. The final publication is a letter to the editor and the author's reply to POTS, a neural immune disorder with cardiovascular manifestations. So that brings us to the end of our July 2026 podcast. I'll talk to you next month. And as always, thank you for listening.